Konko sanibonani babukela uMangqolosi omuhle usijongo kanjalo usefikile eniphathele njengenjwayelo ulwazi olunzulu phela ngamalungelo enu. We live here kumamba phambili SABC 1 eMzansi for sure. Mbukeli-ke sekuyiminyaka phela abantu balapha eNingizimu Afrika behlupheka mayelana phela nokuthola usizo lwezempilo olusezingeni oluncomekayo ikakhulukazi uma bengenayo imali. Kodwa-ke ukulungisa lokhu phela uhulumeni kule nyanga umemezele ngomthetho sivivinywa womshwalense wezempilo kwazwelonke phecelezi the National Health Insurance ukuthi phela wonke womuntu kulelizwe akwazi ukuthola ezempilo noma ngabe akanamali. Emva kwethuba-ke I'll open up the lines njengenjwayelo. You can call us 011-714-6918 or 714-6919. consumer@sabc.co.za is our email address. Sikhona futhi ku Facebook and Twitter. Okwamanje mbukela sihlale phezu kwendaba yethu yanamhlanje. Njengoba bese ngishilo mbukela ukuthi umthetho sivivinywa we-National Insurance Health Insurance udlulise kule nyanga eParliament. Abaningi-ke bayawamukela lo mthetho yize abanye bebona ngendlela ehlukile. Kodwa-ke nawe mbukeli phela uzothola isikhathi sokuthi uzwakalise owakho umbono ngaphambi kokuthi umongameli awufake njengomthetho oyisivumelwane wezwe lonke jikelele. Ngaphambi kokuthi sizwe kabanzi-ke nge-National Health Insurance, uMadlamini uMadli wenze nalupha.
Imibiko lehlatimulisa umtimba ngesimo setempilo lapha eNingizimu Afrika ibonisa ukuthi tempilo lidvonsa ngeligiya lekugcina. Takhamiti letingetulu kwa 80% lapha eNingizimu Afrika telashwa etibhedlela tahulumende. Bese kuthi letingephansi kwa 20% tisebentise tibhedlela letitimele. Loku-ke kudala ukuthi kungabi nekuniketela kwetempilo lokulinganako lapha eNingizimu Afrika. Hulumende ufuna kubeka umthetho locinisekisa ukuthi wonke uthola tempilo ngendlela lefanako.
The day we've all been waiting for has arrived today. The NHI National Health Insurance Bill is being introduced to Parliament. This brings us to one step closer to our goal of implementing the National Health Insurance and fulfilling our constitutional obligation to provide quality universal health care for all.
Bathengi labane medical aid belashwa etibhedlela letitimele babhadalelwe yi-medical aid. Labo lebete i-medical aid baya etibhedlela tahulumende. Kepha-ke kusungulwa kwe-National Health Insurance noma sikhwama sahulumende setempilo kusho ukuthi nalabo lebete i-medical aid batawukwati kwelashwa etibhedlela letitimele babhadalelwe ngilesikhwama se-National Health Insurance. Noma labanye basemukele lesimemetelo sendvuna yelitiko letempilo lamanye macembe politiki asihlaba sihlikita.
I'm willing to go to whichever court in the land to fight this matter. Because as it's currently put forward, we already now I'm raising this concern up front to say don't undermine the power of provinces. It is expressed in the Constitution of the Republic. We cannot be passing laws in Parliament that will not pass constitutional muster.
That is going to ruin the whole health system in South Africa. But the fact of the matter is the government must do their work to ensure that we get quality services.
Inhlangano yebetempilo letimele, i-South African Private Practitioners Forum, nayo ibeke luvo lwayo kulomunye umsakato we-SABC.
SABC doesn't believe that the NHI model as it is there is going to realize what is indicated that it should realize. So there's a distinct difference between the NHI and universal health coverage. NHI is one model for that. And the fact is that this particular model is not suitable for the South African environment. We simply do not have enough money, we don't have enough healthcare professionals, and we don't have the administrative capacity in South Africa to implement something on such a grand scale.
Lo mthetho we-NHI usayobungudwa eParliamente ngaphambi kwekusayinwa ngumengameli. Letiko letemphilo likalekisa ukuthi le NHI itawuqala kusebenta ngalokuphelele eminyakeni wanga 2026. Zinhle Dlamini Mugabe, Yilungelo Lakho.
Zajika ngempela izinto mbukeli sibonge kakhulu kumadli uMadlamini Mugabe ngalezo indaba manje mbukeli ukhuluma kabanzi phela nge-National Health Insurance. We're very pleased to welcome our guest today sinayo usisi uNondumiso Khumalo ovela eCouncil for Medical Schemes. Siphinde futhi samukele udokotela Lwazi Manzi yena ke ungusomlomo phecelezi spokesperson sikaNgqongqoshe wezempilo kwaZwelonke. And last but not least, we do have in the center our only gentleman today. We do have Dr. Chris Archer, yenage umele South African Private Practitioners Forum. Ladies and gentlemen, what a pleasure. Thank you so much for joining us. Good afternoon.
Good afternoon.
Welcome, welcome. Let's start with you, Makhumalo. Awusichazele kabanzi siyabona lapha umbiko ukuthi abantu abaningi they are the for or against lo mthetho ukuthi ufakwe for uzwelonke. Nina nimeke uphi njenge medical schemes eMzansi?
Well, Tina, Council for Medical Schemes, as you will know, our mandate actually it involves ama medical schemes aqhuba kanjani business yabo with an intention to ensure that our members are protected all the time.
Okay.
As you understand, our members are kokai premium each and every month end, so there has to be a value for the malabai kokai mabetenga lama medical scheme. So kuningi sikubonile ku industry since the inception or establishment of a Council for Medical Schemes.
Yes.
I can speak about a variety of cases where there's been huge level of non-compliance in the industry, members paying excessive out-of-pocket payments.
Amounts,
yes,
yeah.
like a lot of money. I mean, we collect data on almost annual basis, and we report on this data where you will see the type of complaints that the Council for Medical Schemes is actually expected to adjudicate, where people are running out of benefits and they have to now either pay out of pocket if abanayo imali yokhokha mele bahambe baye kwi-state bayo access alama benefits, and over and above that they are still expected to continue paying those premiums.
Absolutely.
Because if we calculate your premium is a kicker out medical scheme, you know, whether your out of hospital benefits are exhausted or not, you are still expected to pay those premiums. So kuningi sikubonile, and with these experiences now and engaging with the publication of the green paper ye National Health Insurance as well as the white paper, siyabona ukuthi kahle kahle that at the moment is the best way to go, you know, this National Health Insurance route. Because ngibonile lokubokuvezile lapha one of the stakeholders was actually saying ukuthi NHI as a model for achieving universal healthcare coverage.
Dr. Archer, when Makhumalo. Dr. Archer, we saw in the insert there that your body doesn't necessarily feel that this model is suitable for South Africa. So is that the view that you guys are off in terms of the rollout of this NHI? And why do you say so?
Well, can I perhaps just preface that by saying we support universal health care.
Yeah.
We recognize that there has to be reform both in the public and in the private sector. And I think right from the outset, I'd like to state that we must accept the bona fides of everyone who's involved in this process of negotiation and discussion. Everybody wants the same thing, essentially better health care for South Africans.
Yes.
The question is, what is the best route to take to achieve that objective? And our concerns are not with universal health care, but with the adoption of this particular model, which we feel for a number of reasons is unsuited to the South African situation as we find ourselves now. We are living in a severely economically constrained situation.
True.
There is no money to spend beyond what we've got already on additional services. So we have to find a method of using the services that we've got within the budget that we have to achieve this objective. And NHI, the projections on what NHI may cost have never really been tackled. I mean, we've heard Olive Shoshana the other evening saying 268 billion. Well, that number was in 2010 terms at the time of the Green Paper.
All right, Doctor, we'll get into the nitty-gritties. I wanted an intro just basically to hear your views. When Ntokazi, Dr. Lwazi, obviously you guys are for NHI nisilethela yona, but what are your views in terms of abantu ukuthi baye oppose nalaba bathi cha? I mean, research iyasho ukuthi over 83% of South Africans are not on medical aid, meaning ukuthi mawugula wena kumele uhambe uye ekliniki or emtholampilo kahulumeni, of which you might not necessarily get the best care leyo kumele ukuthi uyithole Ntokazi.
Ngiyabonga lo mbuzo wakho. Ngifuna ukuqala ngokuthi njengoba ngikhuluma mina, apart from the fact that I'm a spokesperson, ngikhuluma njengomuntu osesebenzile. Mina ngangisebenza ku-emergency for 12 years. So mangikhuluma mina ngicela ukuthi abantu bazi ukuthi ngiyazi ukuthi ngikhuluma ngani. Ngiyazi mina sengazibona lento akhuluma ngayo usisi uNondumiso lena ngiyayazi sengeke ngababona abantu ku-private bengena bathole usizo mhlambe kangaka and then it's no sorry ama benefits akho they run out baphelele ku state care. So njengoba sithi thina ke sifuna ukuthi sithi make sure ukuthi wonke umuntu is covered under NHI, siyazi ngoba siyayenza vele leyo nto ngisho nalabo abantu abane medical aid siyabakhava mangabe siphelele medical aid yabo. So hayi ukuthi thina senza into esigakaze senze esigayazi siyayazi futhi siyazi ukuthi izobiza malini lento. iNHI isukela kumthethosekelo othi wonke umuntu unelungelo lokuthola impilo, quality health care lapha eSouth. So it's a constitutional right. Njengoba sesibhalile le NHI as a bill njengamanje asisuki nje noma ikophi sisuka kumthethosekelo. So iNHI ihambisana nse nomthethosekelo. Ayikho into yokuthi iNHI it offends the constitution. It's very constitutional. The state law advisor isize nayo futhi ya issue statement esho ukuthi ena no cha iNHI ibhinje ngoba injeni yahambisana nomthethosekelo. Kungakho sikwazi ukuthi even sifike parliament ngoba siyazi ukuthi yahambisana nomthethosekelo.
You know, Doctor, ngifuna ukubuza emva kwekhefu ukuthi yini then abanye ama groups njenge group yabo Dr. Archer becabanga ukuthi le model ayikho necessarily based for South Africa at this current stage. So we're going to talk about that and a whole lot more after the break. We are talking about the National Health Insurance Bill that of course still needs to be signed into law. Siyazi ukuthi uhulumeni ke uyasho ukuthi wonke umuntu kumele abe ne-access to better healthcare services noma ngabe unayo imali noma ngabe cha, because masugula mbukela usuku usugula ukuthi uvelaphi kumele uthole usizo. Yilungelo Lakho, we're back shortly after this. Bukeli sikhuluma nge-National Health Insurance ekuthiwa ke izovikela wonke umuntu wala eNingizimu Afrika, iphinde futhi uhulumeni akwazi ukuthi akuthengele umuthi mangabe wena uyagula, ukwazi ukuya kubantu abanolwazi olunzulu mayelana nalo msebenzi wokuthi phela abahlengi abazokusiza ngawo. Bukeli, we do have a caller on the line now. Ungenza njalo 011-714-6918 or 714-6919. John, all the way out in Davidson, you are first caller. Sawubona. Kungiyaphila nsizwe unjani?
Ngiyaphila. Ngicela ukukhuluma noJohn eDavidson kodwa ekhaya kuseMpumalanga.
Yebo baba.
Lo mthetho osivivinya uzona uhulumeni ngiyawusekela kakhulu. Siyeke amaqembu epolitiki lawathanda ukuphikisa nezinto ezi-right esisiza umphakathi wonke waseDavidson. Njengamanje mina ngikhuluma ngigulelwa umama walendlu.
Yebo baba.
Isikhathi eside from 2014 in private part akapholi singihambela kulezi izibhedlela zikahulumeni inyanga zesintu akasizakala kodwa mhlambe kube kulezi izibhedlela eziphezulu mhlambe ngabe siyosizakala njengamanje. So asowayekeni amaqembu lawa athanda ukuphikisa nezinto ezibenefita umuntu wase-South Africa njengo-ODA nobani umthetho lo right bengawuzwa kahle kodwa sengizwa kahle ngoba sewukhuluma la eTV njengamanje.
Siyabonga
John kakhulu noma ize uzoqala ukusebenza ngo-2026 kodwa isikhathi leso sikhathi kube nje uqala ukusebenza mhlawumbe ngonyaka ozayo.
Hayi ungawari. Ungawari Nsizwa, siyabonga kakhulu ngalo mbono. Well, basically, Dr. Acho is saying that he does welcome the act because obviously this means that more people that previously could not have access to better healthcare services are now going to have better care facilities. And he says, I mean, he's gone through, is it the mother that is sick? The mother has been sick for years. They've gone through all types of different hospitals and people, but if they had money, he's thinking that, you know, they would have resolved the problem. So, Dr. Manzi, let's go back now to ilokuzani NHI itself. Izosebenza kanjani? Nangu John ethi nje siyayizwa ukuthi thini kodwa singakayi understand kodwa how anisitshele more.
Ngiyabonga lo mbuzo ngoba siyathanda ukuthi sikhulumele phezulu kodwa abantu abakakazi ukuthi izosebenza kanjani le. So into engizoyenza mina, I'm just going to walk you through ukuthi what is going to happen. Okay. Asithathe asithi mhlambe uphethwe iBP. Okay. Let's say futhi you're young hypertensive. Ngifuna ukusenzisa ukuthi young hypertensive ngoba ngifuna ukuthatha all the way to the end to complex disease management, right? Uma uzodinga uya ku rota scale for a transplant. Sasiqale phansi ke. Una 35 uphethwe iBP hayibo. Uyiwayo uphethwe iBP. Kodwa uphethwe iBP uyagula nje kancane awuguli kakhulu. You know, awusiyento ephuthumayo. So uzoya ku GP. Now, few steps back. Wonke umuntu fanele abhalise ku-NHI already sesibhalisa abantu abawu-42 million. Okay, so sesibabhalisile abantu abaningi.
Babhaliswa phi Dr. Manzi?
So indlela ozobhalisa ngakhona uzothi okay, mina ngicela ukukhetha le GP noma le clinic ukuthi kube indawo yami lapha mina engiyakhona. Cha akusho ukuthi mangabe uzithola uvakashela ugogo enqothi wena uhlala ukuthi cha ngeke usakwazi manje ubona umuntu ethi cha senzela nje ukuthi sazi ukuthi uhlalaphi ubani, who's your primary point of contact uma ngabe sidinga ukuthi sithumele information kudokotela omaziyo noma kwiclinic ekwaziyo, keep patient records etc. So uzobhalisa kuleyo clinic yakho noma kuleyo GP yakho, right? So fake kwi-system. Leyo system futhi izohambisana ne-system lena vele ye-home affairs, sizosebenzisana ne-home affairs senzela ukuthi mangabe khona esidingayo wonke ama
private surgeries
wonke ama GPs sizosebenzisa wonke umuntu manje. That's the thing. Yabona inkinga njengamanje sinama system awu2 angaxhumani. Sine system ngapha private healthcare, a system ngapha government healthcare. Le system lena it looks after 16% of the population. Le system lena it looks after 84% of the population. Isithini cha. We have got our whole population to look after. Kodwa lapha boyithu abakhulumisana asibahlanganise sisebenzise infrastructure ekhona singakhi into entsha sifuna imali ezintsha exactly. Asebenzisa lokho esinakho la ekhaya kodwa ongasebenzisani njengamanje sikuhlanganise kusebenzisane konke for everybody. So asisho imali ezintsha nje wadesho udokotela cha asisho imali ezintsha asisho infrastructure and sisihlanganisa khona lokho esinakho vele abantu abakusebenzisayo. Okay, asibuyelene ke kulomuntu lona ophethwe iBP ona 35 uzongena ku GP yakho usebhalisile unekhadi imbone iGP ithi GP ayibo une BP una 35 asenza amagazi. How amenza impela amagazi iyazi ukuthi izinto zakhe asebenzi kahle wena kuzomela ukuthi ubone maybe a physician or asithi nephrologist asithi uyabona specialist. So asithi uyabona straight ukuthi cha kunenkinga enkulu lapha straight to nephrologist. So this is even a super specialist. So why am I saying this? I want to make a point ukuthi when you get referred akusho ukuthi you're going to go through every little step. We are going to make sure in the bill ukuthi odokotela bayakwazi ukuthi bawenze those kinds of decisions that are clinically sound to be able to refer you appropriately and timeously. So kunale perception or otherwise it's a narrative that's driven ukuthi uzobona iGP mase ubona abantu.
And by the time
usuyashona cha yikho leyo nto vele. That's not what happens now. That's never going to happen in the NHI. NHI is all about quality healthcare. Uzorefera ngesikhathi kumuntu odinga ukuthi umbone ngaleso sikhathi odinga ukuthi umbone ngaso.
Dr. Manzi awume kancane lapho. So Dr. Acho, you hear what she's saying. Basically, they're going to use the current resources that they've got to ensure that everybody is speaking in the same voice, to ensure that everybody receives the same type of medical care.
Well, you know, we already have universal health care. But I agree, the problem with the model that we've got at the moment is it's inequitable. There's, as you mentioned, 16% of the population who belong to medical schemes, who probably, because of that fact, have better, quicker access to good health care.
Yeah.
But the balance do have access to the same full range of services through the state. but those services, the quality of the services in some areas is lacking.
Questionable.
You know, so and there are long queues. So I don't see how changing to national health insurance, it's not going to magically increase the number of facilities. It's not going to increase the number of providers.
You know, Doctor, I'm going to let the other doctor get back to you on that, but I want to quickly take a caller before we go to the ad break. Umamlindi eSoweto. Mamlindi, sakwamukela ohlekela Ntokazi umbuzo noma umbono.
Sanibona ninjani?
Siyaphila Ntokazi kunjani?
Ngiyaphila.
Yebo, singakusiza kanjani?
Igama lami nguLindi.
Yebo ma.
Mina ngicela ukubuza nje ukuthi this NHI it's entitled for who? Is it for people who are working or people who are not working? Ne?
Yep.
And then secondly, the budget year healthcare system. Kahle isebenza kuphi? Because some of abantu ayibasebenzeli abanye abasebenzela.
All right.
And there's so many hospitals around, and on top of that, what are they doing? And most of them say they are ama hospital care.
Yeah.
So another thing, Mina, I am working, ne? I've got a medical aid, ne? I'm paying 3,500 on a monthly basis. And then I only took my reading classes. When I went to buy medication, they told me, I've got insufficient funds.
How?
So I understand, Uguti, this year, I only spent 3,000 rand, but I don't have funds anymore.
Into ebesikhuluma ngayo leyo Ntokazi.
Because if you can calculate that 3,500 on a monthly basis, for the whole year, it's a lot of money.
It is.
And I've never been hospitalized. And medical aid, I only use it on my counters when I go to the chemist. Ne? And usually in a year, I only spend plus minus 2,000 rand. So I don't understand, Uguti, this healthcare is and this NHI is going to assist who and it's not going to assist who.
Ntokazi yazi usenhlanhleni ke namhlanje ngiphethe indaba ezimnandi. uDr Manzi uzokuchazela ukuthi njobe bese chazela ukuthi isebenzela wonke eningizimu Africa, whether you're working or not. A very good point, very good question. Sabonga Ntokazi usisilindi. Sicela ubuke lapho kumabona kude wakho. We're going to have more of those answers. We're going to be taking your Facebook messages and also your calls on 011-714-6918 or 714-6919. Yilungelo Lakho ne-NHI khamba kanje. Siyabuya. Welcome back. Mbogeli sikhuluma nge-National Health Insurance le kuthiwa ke uhulumeni ufuna ukuyifaka ukuze phela sonke lapha eningizimu Afrika sikwazi ukuthi mesigula sikhona ukuthi siye noma ikumuphi umtholampilo, noma ngabe unemali noma ngabe awunayo imali, ufike uthole usizo olukufanele. Ngihleli lana no Dr. Archer, no Dr. Manzi kanye no Makhumalo, and we are getting those answers. Let's quickly see ukuthi nithini lapha on our Facebook or Twitter pages. Ulindo Thobelani Mfekai uthi yes, this system can be very helpful, more especially to people who live in the rural areas, although there will be some corruption. Of course, Umamanzi is still going to talk us through that because ngeke le mali ekuthiwa izophathwa ngempela iningi kakhulu. Unazim Grootboom uthi will this healthcare system help the poor, especially in rural areas? I think everybody wants to know ukuthi emaphandleni bazosizeka yini labantu, and how are they going to do it if it is implemented? Thank you Nazim Grootboom. Ubonga inkosi NS uthi no, sonke kufuze ke sithole usizo olufanayo. Akusho lutho ibala, but eMzansi ngeke kulunge ngoba phela siyaxhashazwa nasezimalini kuyohlezi kunje. Makhumalo, let's go back to our caller lana uMamlindi. uMamlindi ufuna ukwazi ukuthi kwenzakala kanjani ukuthi ekhokha u3.5 njalo ngenyanga. All she did was go to your optometrist, ilokuzani eye test mhlambe u120, ama glasses ke ungathola ukuthi they even less than 3,000 rand included including iframe. Uthi manje-ke ngoba kade ayekhokha from January to December, yinto ayithathile nje ama-specs. Kwenzakalani ukuthi ama-services asedepletiwe ntokazi?
Nayo-ke inkinga, that's why bengisho ekuqaleni ukuthi sibona zonke izinto ezinjalo. I mean, icase le ayikhuluma ngayo, it's not unique, it's a common thing. But inkinga, it goes back ukuthi lama benefit option bawa indlela abawenza ngayo, like distribution of le mali ozoyikhokha per month, lo 3.5. I percentage enkulu iya kuphi, I percentage encane iya kuphi. So bakhona lokho kuthiwa ama risk benefits. So bulk of the premiums that are paid by all the members of the medical schemes goes towards ama risk benefits. Ama risk benefits ilama benefit athi just in case ungangena esibhedlela because ube nalenkinga enkulu medically, engafuni out of hospital care only, efuna maybe in hospital care, kumele ukuthi ischeme sibe nemali sokuthi sikhona ukukhokha. Manje uzothola ukuthi sometimes lawo ma risk benefits mhlambe unida uncedo olu far above ama contribution owawenza ever since wa join ischeme, for example. So you as an individual ngeke ukwazi ukuthi uzisubsidize leyo mali leyo ingena in the big pot where there is pooling. Inkinga ngale current system ukuthi that pooling is only existing for only 16% of the population. Medical aid, but even if ikona, it's not sufficient for certain conditions. That's why uzothola ukuthi they still go to the state, especially abantu abanida care kuma super specialist, because those really you find them in the state. I was told you go public, I mean go private sector. But now ge ama out of hospital benefits normally depend ukuthi I member ithenge I option enjani. Uzothola ukuthi lama options ahlukile. The more you are able to pay, the more mhlambe ungathola slightly richer benefits kuma out of hospital benefits. But if awunayo imali uzothola lokho okuncane, abantu abaningi futhi baba nama hospital plan ba end up bengenawo nokuba nayo ama out of hospital benefits. But in her case angacabangi ngokuthi ngoba ukhokha 3.5 mele athi 3.5 times 12, and then that is the money that she's got because akanakazangena esibhedlela. Le mali leya ayikhokhayo ihamba iyo cross subsidize laba abangena esibhedlela ngoba we are in this closed environment that has its own challenges, but there is some pooling. But CT now CMS, because sikubonile konke lokho. So we are actually advocating for national health insurance because national health insurance ithi kuzoba khona one fund. So wonke umuntu uzocontributor, I mean law okhona ucontributor according to the bill will contribute to the fund, but there will be a bigger pool of people who are participating kule fund. So it means ukuthi siyakwazi ukuthi si cross subsidizane better than is situation of medical schemes. And I mean Dr. Lwais also explain ukuthi even ama out of hospital benefits, as long as ama members follow the referral pathway and they access a care in a designated provider that would have been accredited as an NHI provider, they're not going to have an issue ukuthi hayi manje ngiphelelwa ama benefits, hayi manje mele ngikhokhe out of pocket payment, mele ngidayise indlu yami, imoto yami, so that ngizokhona ukuthi ngiafford, you know, like private health care.
I want to ask then Dr. Arch, I mean then the issue, it sounds like that you have then becomes the issues around how this the funding model is going to be implemented. Let's talk about the fact that there's 16%, around 16% of about how many people do we have? About 57 point something million in South Africa. That's 16% versus the 83% of the people that heavily need care but don't have access to it. So the one sector is literally collapsing the other, and you look at the private sector, it's got exorbitant prices.
I disagree. You know, the problem is that 16% are people who can afford medical schemes.
Yes, that's true.
There are many more people who access the private sector who pay cash out of pocket. So it's not strictly just 16% have private care. There are people who are not medical scheme members who also participate in the private sector by paying cash. Now, remember that the whole system is based on pooling of funds, and that the healthy fund the ill. So when you are young, you are going to be contributing more than you are drawing, because that's the only way that medical schemes can survive, is that there are people contributing to the fund
Absolutely, yeah.
who are not drawing from it.
It's a rotational
But as you get
relationship,
older,
yeah.
as you get older, I mean, your call on those funds gets greater. So that's where the balance happens. So for a young person who is paying a lot of money towards a medical scheme, yes, they're going to feel that they're probably not getting the benefit that the money that they're contributing should be providing. But ultimately, when they get to the end of their lives, when their requirement increases, hopefully that pool will be there. Now, if we collapse that pool into one huge pool for everybody, the National Health Insurance Fund, the people who currently derive benefit from that medical scheme pool will be sharing that money with the rest of South Africa. So the rand value of that money in the medical scheme pool will devalue. The medical scheme member will end up getting less value for the money they are putting in because it's been shared with a much greater number of people.
Dr. Manzi is disagreeing there, but let me quickly take a call, and then Dr. Manzi, I really want to get your input there, because we also heard about stuff like top up. If you can still keep your medical aid, but uzoyibiza top up, it's just that wonke uzoba namalokuzana ne-access ukuthi uyakhona na ukuthi ungene e-life kuphi e-4 ways kuphi uhambe uyothola phela i-doctor no-specialist esilapha. Monwabisi at Delft e-Cape Town. Sekwamukela ohlelweni umbuzo noma umbono.
Mawala sisi kunjani?
Ndiphilile tata, kunjani?
Ndiphilile mani.
Wetata.
Ngicela ukubuza apha ku-Dr. Manzi, ne?
Yeah, wetata. Buza tata.
One. But what does it mean about our local clinics and our public hospitals? Because it seems as now everyone is going to be shifting. Is it going to everyone are shifting to private hospitals, or how is it going to work? And my second question is this: what does it going to mean now for us? Let's say for people who have medical aid, is it going to be necessary to have medical aid or what? I just want to know about that, man.
All right, siyabonga kakhulu utata uMonwabisi lapha. Very relevant questions coming through. Yazi ngenza lo msebenzi wami namhlanje ngizohlala nje ngirelax mina. I'm not asking any more questions. Please call 01171469118 or 01171469119. consumer@sabc.co.za. Sikhona futhi ku Facebook, Twitter, and of course on those SMSs. TJ, ngicela ungihlanganisele ama SMS so that I can read at least one or two. Mesibuye emva kwekhefu. Bukeli, welcome back. Sisadingida udaba le-National Health Insurance okusho ukuthi phela wena uhulumeni ufuna ukwazi ukuthi mangabe uyagula uphethwe noma yini, 1 uthola umuthi, 2 uthole ukuthi uye kudokotela ozokwazi ukusiza, be it i-specialist esingabiza noma imalini, lapho ke uhulumeni bese eyakhokha. Dr. Manzi uyasho lana uDr. Archer uyabeka ilokhuzana indaba yakhe. Ucabangani wena when it comes to indaba zelokhuzana? We're talking about ama funding models nokuthi 16%, if you look at it as umuntu uzothi but bancane labantu abakhala ngokuthi lo 83% awungaserviswa, bona abangatholi i-access, the same access to lama health care facilities abawatholayo, which are top notch.
Okay. Just to bring a little bit of anecdotal evidence into this whole thing.
Yes, doctor.
Mina, I've worked in public hospitals. I've worked in private hospitals. Now, I'm going to take the example of Imaritzburg. Ngangisebenza 8 Deni, and I worked at Hilton Hospitals. These two hospitals are not very far from each other. Kukhona nje highway engemuva lapha abaxhumanisayo. 8 Deni, I would say, I can't remember their numbers exactly, but I am sure through that emergency unit, same as the Somerset Hospital lapha ngangisebenza khona, we would see upwards of about 4,000 people a month. These are people, this is just head count coming through the emergency unit, and then as emergency doctors, we disperse them. Guess how many patients I used to see at Hilton Hospital, private hospital? Sometimes I would see 0 on a night call. What? Sometimes I would see 3 on a busy day at Hilton. Maybe I'll see 10 to 15 the whole day.
Underutilization.
The whole day. But Hilton has got beautiful emergency unit. all the facilities, everything.
So zihleli mamanzi azenzi
Sihlela
lutho.
senze lutho thina ngiyazi mina ukuthi 5 kilometers away ziyapompa laphayana e-Eden. It is unjust. It is quite downright unjust and unconstitutional. If you want to talk about unconstitutionality, DA, awuhambe uyobona ukuthi kwenzakalani laphana eHilton, kwenzakalani lapha e-Eden. It is not on. It's unacceptable.
Maybe Dr. Mab, then maybe talk to us about the fact that those that currently have medical aid, how does this NHI then affect them? Because I think iwariyabo ukuthi all right sharp nizofaka lento ka wonke which means ukuthi sengizofana nami zomele ngime kwi-queue ukuthi ngiyobona udoctor ebengivele engilinda ukuthi uzongibona ngiyi-patient yakhe yodwa within a week.
Okay.
You know?
So number one, masithi thina a healthcare facility is going to be accredited by NHI. Kushathi NHS ukuthi ngifuna ukuqhathanisa ne-NHS yase-UK, which is the same thing. Masithi thina a facility is going to be accredited in. Isho ukuthi leyo facility has to pass through the Office of Health and Health Services Compliance. Leo office iyona ezosho ukuthi this thing it scores so much, therefore it can be accredited in. One of those quality control measures is going to be waiting times.
Okay.
Therefore, it's going to say if your waiting times are unacceptable, you will not be contracted into NHI.
Okay.
Now, I know what everybody's saying out there, but yongeke phela izisebenzi lento ngoba ama-clinic ethu nezibhedlela zethu ezilapha they're never going to pass because yes, and siyavumelana nabo siyasho ukuthi yebo siyazi ukuthi this is what's happening now. We are saying it's unacceptable. We have got 7 years. NHI is going to be implemented in 2026. We have 7 years to sort all of that out. We will sort it out because we want to make sure. Yabona ayikho into ezowisa NHI njengokuthi by the time implementwa ama-facilities ethu are not the facilities of choice. So thina siyakwazi ukusihlakaniphile thina safunda. Siyakwazi lokho ukuthi into ezowisa NHI nje iwise ingakaqali ukuthi ama-facilities ethu kungabe wona efunwa abantu. Therefore, in this 7 years, into esoyenza thina is to make sure ukuthi by the time accreditation process starts, wonke ama-facilities are going to score 80% angene sikwazi ukuthi siwa-accredite. Now, what does it mean for everybody? Not whether you pay medical aid, not what does it mean for everybody? It means ukuthi wena. Once you get that card, whether you find yourself in Nquthu or you find yourself in Cape Town, you know exactly what level of service to expect.
It's the
same thing.
That's what
it's
we
going to be
want.
and that is why some functions must be centralized. How are you going to make sure all of the standards are the same? You can't. You have to have a central function to ensure no, siyazi we've got an overview of all of the facilities. These are the acceptable standards that must be met before you can even accredit in, and therefore this is what is expected to be done and this is what we want. As a province, akusho lokuthi anikwazi ukuthi nifake imithetho ezothi make sure ukuthi nikhuluma ngezinto ezenzakalayo kwi-jurisdiction yenu. That is why ama-concurrent powers lena sikhuluma ngawo afuna ukuphikisana nathi abanye abantu, they are preserved. Awasusanga kule bill. They are preserved. Senzela khona ukuthi uma ngabe let's say a case at any inkinga yenu, your big problem is the HIV and AIDS. And you can deal with that. You can make the laws ukuthi you deal with that. Uma use Cape Town and inkinga yenu is hypertension and diabetes, you can deal with that as a province. Thina as a state sizovesa nesikhokho mangabe uthi sicela ukuthi nikhokhe kuleyo facility. That's really what it comes down to.
You know, Makhumalo, maybe talk to us about this because I feel ukuthi izo assista kakhulu. We're talking about services that run out mid payment abantu. Now, kunama services that are going to be I think udoctor uzosichazela kabanzi in terms of procedures. There's certain procedures ezizoba in line with the NHI that you can do and certain medications also that you can do. So do you think ukuthi izo alleviate some of the issues enitholayo nina abantu abacomplaina ngazo ukuthi mase sifuna medication kade sikhokha asithola ukuthi whereas lana mangabe ucontributile noma ngabe ucontributanga as long as usudinga umuthi you're going to get the necessary medication.
Kahle uyibeke exactly like how it's going to happen and izoba benefita kakhulu ama-members ama-medical schemes.
Yes.
And I think enye question engazuthi yenza abantu babe nervous kakhulu ukuthi oh ngizaba nayo yini if nginayo imali, can I buy my medical scheme for complementary cover? So bill is very clear. Iyasho ukuthi, you know what, just keeping in line with international experience, our medical schemes will still be able to provide complementary cover. And logo uyakubona kubhaliwe kwi-bill. Sometimes ngiyacabanga ukuthi abanye abantu mhlambe baze bangazwa kahle ukuthi kahle kahle NHI ingane ngoba mhlambe abafundi abachazekanga kahle and
blame Dr. Manzi lapho because
the language le
abachazi.
abayisebenzisayo but just to finish,
Yes,
our medical
Christine
schemes
Ntokazi.
will still be there,
Yep.
you know, but they won't be allowed to play a duplicative cover. So logo okucover ku NHI, ama medical schemes ngeke avumeleke ukuthi akukhave.
Wayibeka
And
kahle.
CMS organization mina ngisebenza la yona,
Yep.
umthetho wawo will be to make sure ukuthi akukho duplication of service package that are being delivered and accessed.
Saseyivekela imali bantu bakithi. Mbukelithi siphinde futhi sithi shalele ngaseyitolo. We're taking those calls, those Facebook and Twitter messages and also your emails as well as SMSs on 33721. Yilungelo Lakho, we're back shortly after this. Bukeli, welcome back. It's our final segment. Again, ngezwa kuthiwa nje sha Alisha ngoba phela sekumele sirephe uhlelo. Doctor, you were raising a very important question while we went on ad break, and then I want Dr. Manzi to address it very quickly, Doctor. We've got about 5 minutes.
Yes, look, there's confusion in the bill at the moment about the role of medical schemes going forward.
Yes.
On the one hand, it states that medical schemes will only be there to provide for the funding of complementary health services. That means services such as cosmetic dentistry. And anything that's provided through the NHI will not be allowed to be funded by medical schemes.
As she mentioned, yes.
So my question is, why would anyone wish to belong to a medical scheme and pay the sort of fees that they are currently paying if all they can access through that scheme is esoteric services such as cosmetic dentistry? The other confusing aspect is the opting out of the referral process. It states in the bill that if an individual chooses to opt out of the referral pathway, then the NHI fund will not fund those services.
Yes.
In which case they will need to rely on their medical scheme. Now, unless the medical scheme is able to provide and pay for those services, that the section that refers to only complementary services,
yes,
the scheme won't be able to fund the services that they're opting out of.
This is where the concerns about the job losses and so forth
needs to be clarified.
Comes from. Dr. Manzi, osichazele lapho Ntokazi, because I think we had mentioned le ndaba ye top up ukuthi kahle kahle mune medical aid usengakhona ukuthi uyisebenzise, but what does it really mean njengoba esho udoctor, because sifuna ukwazi mhlawumbe mungasichazela in layman's terms ukuthi what would be the exclusions ke izinto engeke zigadwe yi-NHI.
Okay, sure. Ngicela nje ukuqala nje ekuqaleni ngisho ukuthi our business and government is to adhere to the Constitution and protect people's rights as laid out by the Constitution.
Yes.
That is our business as government. So yiyo lento lena kufanele siyivikele kwasekuqaleni.
Okay.
Okay. We have devised a system that will ensure that everybody, whether you are able or unable, will have access to health care. That is the first thing we must concern ourselves with, and we cannot lose focus in that regard. Vele abantu bazofika nempikiso yabo, kodwa thina that's what we must focus on, right? Therefore, i-bill njengoba esho ukuthi what it has set out in terms of our medical aid ukuthi lokho thina that we won't be able to provide in NHI. And by the way, NHI says very clearly in the bill provides comprehensive services. In the case of Lomuntu Lono na 35 in the beginning on BP, we are going to cover him from the time he sees his GP, gets those bloods taken, sees a nephrologist, gets their transplant, uzobenga khokha ngisho nesent.
Athole ne-medication.
Athole ne-medication afterwards and said akazukhokha isent lapho.
All right.
You try and get that done in the private
All right.
institution. But ngiqede ke sorry. So that complementary cover, the medical aids, Discovery, they came out with a statement. As far as they're concerned, they support universal health coverage. They see that the bill is very much in line with universal health coverage, and that is a system that is going to protect universal health coverage. And as far as they're concerned, they're not only supported, but they see plenty of opportunity in providing complementary cover within that environment. They have all of the brain power to be able to find sustainable models for within NHI.
Dr. Manzi ngempela shuthi uyayifila lento. Let's take our final caller for today. Uthelani kwaNongoma insizwa yangakithi ngiyakwamukela ohlelweni umbuzo noma umbono uthi nje qaba kancane ngoba phela sesiphelelwe isikhathi. Delani.
Yebo mama.
Kunjani nsizwa? Yebo.
Umbuzo mama uthi umbuzo wami since ngoba kubonakala ukuthi uhulumeni uzawubhadala lamabhili wabantu le ngithi imali le ezophuma government ezofakwa kwi-NHI ngeke i-affect amanye ama-service wabantu because izosidinga more money khona lapho.
Oh, okay. Very quickly, Doctor. I think we had gone through this. Ubuza ukuthi le mali le ezothathwa ifakwe kwi-NHI, ugovernment uyithatha ngoba sezothuka umnotho hayi uyanteka.
Okay, yeah, very good question yenzo ngizozama ukuthi ngisheshe njengamanje. Okokuqala nje just ukuthi wonke umuntu ehlisa umoya kancane asizoqala sintax okwamanje. Okwamanje into esoyenza sinemali vele lena esithatha kwi-national fiscus le mali lena esinikezwa treasuries naleyo mali. Le mali lena sifaka kuma medical aid as tax credits sizoyibuyisa sifake kule mali futhi nayo. So
sikhokha malini thina njengabantu ke per month? Ubani ozobe contributor to le scheme lesi? Ithina sikhipha malini?
Usho so kwi-NHI njengoba ngisho nje sisazoqala thina asikakafike lapho sisaqala. Ngizochaza uzofika nini lapho. Le mali lena sikhokha ko-COID ko-road accident fund zonke lezo zinto nayo futhi izobuya ingene lapha. So sisaqa nje iyona le mali lena sazoyisebenzisa.
Where can they get more details on the government gazette?
Okay.
Is it available?
Yeah, ungayithola kwi-website, so ungayithola kwi-parliament i-bill.
Niyalini ebantwini?
Okay, so i-bill uzoyithola in the gazette number 1, uzoyithola on the parliament website, uzoyithola ku-website yethu Department of Health. Indaba yokungena kumphakathi ke manje sekuyinto yaParliament, it's a parliamentary process now. Okay, so bazomemezela ukuthi bazofika nini kumphakathi.
Right, thank you so much Dr. Dr. Manzi, Dr. Archer, thank you so much. Nawe Makhumalo siyabonga kakhulu Ntokazi. Mbukeli ngebhadi ke sifika kanjalo emaphetheleni ohlelo lethu la namhlanje. Mbukeli sidingida udaba la NHI, but before we say goodbye, let me please go back to an insert that we aired on Monday the 5th nanglo of this month ngesikhathi sikhuluma ngama-yellow bone nabantu abenza i-skin lightening. On the program, we erroneously used images of uTV producer uKatlego Selepe Maifadi. We regret the error and apologize to uKatlego. Yebo mbukeli sithanda ukuxolisa kakhulu ngokuveza uKatlego Selepe Maifadi kuhlelo lethu oledlulile. Okwamanje ke ithi mina nginivalelisa mbukeli umzwile ku-Dr. Manzi uthi there will be road campaigns and everything you will know. Mese kumele wazi ukuthi yini ekumele uyenze mayelana nale NHI. Unfortunately, 48 minutes is just not long enough. From me, u-Alisha Nhlanhla Kajali ngithi ngiyabonga, sale kahle.
Yilungelo lakho